Without further ado, I'm going to let Tom take the lead here, and we'll begin this presentation.
Thanks, Julie. Actually, I'm going to formally introduce you. Julie is Chief Experience Officer for SmartER. She's actually among the first group of certified patient experience professionals in the country. And Julie created the first patient experience department for Edward Elmhurst Health, the organization that we're going to talk about. She really helped guide the team to turn around the immediate care centers. Julie's presented at multiple national conferences, including Barrow, Cleveland Clinic, Braintree, and Press Ganey. She also co-created GREAT, which is a nationally recognized open source communication service standard that hospitals are using. And if anybody wants to check it out, just go to greatservicestandard.com.
Thank you. Well, thank you for that introduction, and now I'm going to introduce you. So Dr. Tom Scaletta is here with us today as well, and Dr. Scaletta is a practicing emergency physician and a medical director of the acute unscheduled care for Edward Elmhurst Health. This includes emergency departments, immediate cares, and walk-in clinics. He's also the past president of the American Academy of Emergency Medicine. He has degrees in mathematics and computer science, and he's also board certified in clinical informatics. Before medical school, he programmed computers for an actual company, and he uses that background to design a patient-provider communication solution for SmartER.
Thanks, Julie. I think that's a long-winded way to say that I'm a nerd.
Not at all.
All right, let's see if I can advance this. So we're going to be talking about the immediate care centers at Edward Elmhurst Health. For those that aren't aware, we are a 3-hospital system in the western Chicago suburbs. We have 3 emergency departments, 7 immediate care centers, 14 walk-in clinics, and they're governed by a single administrative service line. Again, all the acute unscheduled care resources that we have. Going back a few years, in 2014, due to poor performance, the oversight of the immediate care centers were transferred to the emergency department team. We were doing, honestly, a better job with patient satisfaction. The prior administration for immediate care was really focused on corporate health, and the administration really wanted to switch things around. So our 7 immediate care centers are all a little bit different. They all have point-of-care labs, plain radiology, but some have higher grade resources like CT, ultrasound. Provider staffing includes family practice docs, emergency physicians, and APC. The 2 that we're going to talk about as examples of the turnaround are the ones with higher capabilities. So they have CT scans, they are higher volume, combined volume, about 40,000 patients a year, 95% discharged home. The rest are transferred to the Edward Elmhurst emergency departments. So we're going to talk a lot about change management in this program. Change management's a lot harder than coming up with great ideas, as everybody knows. We always talk about the proverbial burning platform, and that started with our C-suite very concerned that the immediate care centers were a sore spot for the organization. There was poor patient and staff satisfaction. There were 45-minute wait times door to provider. Our Press Ganey percentile rankings were in the bottom half. A lot had to do with frankly, disinterested immediate care leadership team at that time. One of the leaders was on the verge of retirement, and the others were focused on occupational health growth and not immediate care. But the administration recognized that they were an important feeder, and they wanted to start improving the reputation and growing the volume. And of course, they wanted it fixed fast, and oh, there was no budget to do it. How often have we heard that? So first, we needed to make sure that our own beliefs supported the change, and that this became our burning platform, meaning the leadership team for the emergency department. So we started thinking that our scope ought to be all the acute unscheduled care, not just the emergency department. As we thought about this and where the future of medicine is going, we thought this was the right thing to do, and that's when we all became committed. And so change really begins with the leadership group. And as a little bit of information on the original burning platform, that term comes from, in 1988, there was an explosion and fire, which you're seeing here on an offshore oil drilling platform in the North Sea just off the Scotland coast. 188 people died, 63 survived. They had to jump 15 stories to the water. They knew that that was likely death, but it was better than certain death. So when we talk about the burning platform, we really should think back about where it started and not use it as a casual term.
In today's reality, you know, we are all faced with, I think, the same concerns, is that, you know, there's a lot of competition growing in our space, and we are constantly having to be very aware of what that competition looks like and how we're going to continue to grow and be able to keep up with that. Not only are we, you know, trying to improve our services, but we also are having to make sure that we're being desirable and, you know, desirable to the different generations that are walking through our doors. So making sure that we're efficient and we're providing service in a, you know, affordable manner, and also in the means that it's easy for all generations to access. So this is something that I think we all can, you know, relate on. Thankfully, our emergency department and immediate care centers have been able to continue to grow, and really that's due to capturing patient loyalty, which is really what we want to talk to you guys a little bit about today. And how do you capture patient loyalty and really understand, you know, the desires and the needs of the patients that are walking through all of our doors?
Okay, so to succeed in this kind of competitive environment, Julie mentioned loyalty. The loyalty comes from realizing a vision. Everybody has to be rowing in the same direction. So we put this together with the Edward Elmhurst vision, that is to provide safe, seamless, and personal care to our patients. So safe represents quality. Seamless is the cost and time efficiency, and personal is the experience that both patients and staff realize. And these really are the essential components of great patient experience. So this model that I'm showing on the screen comes from a person named Noriaki Kano. He was a quality management professor from Tokyo, still alive, born in 1940. His satisfaction model demonstrates the impact of each of those elements I talked about. So I like to think about this from the bottom up. So what we're trying to do over time as we start a new program, a new idea, we're moving from a current state to a future state. And ideally, we're starting at one place and going to a better place with regards to the patient experience. We want to drive this up. So the three pieces are, begin with safe care, which is quality. If a patient, for instance, comes to the immediate care center with a strep throat and you diagnose a strep throat, which is what they expect, you will just achieve basically average. If you don't make that diagnosis, of course, no matter what else you do, you will not achieve a high level of patient experience. So that's where it needs to begin, of course, non-negotiable. Then seamless comes in. So seamless in the setting of immediate care would relate to door to provider, and it linearly increases. So as you shorten door to provider, you are going to linearly increase satisfaction. And then the last is something that's completely unexpected. This is the wow things. And so personal care we could put in that category because we want to have something that isn't delivered anywhere else. So it's almost like we want our staff to treat each patient like they're a good friend, not just a patient. So they will go above and beyond. And that, to a lot of people, of course, is unexpected.
So this is what we call the golden circle. And Simon Sinek is who created this circle. And here he really talks about, if any of you are familiar with him, how do we get people to believe? And you must believe in yourself to begin with. This is truly the equation for success. And Simon will share with you that our successful, inspired leaders really believed in this model. And what they did is they really went from the inside out instead of the outside in. So you have to start with the why. You know, why is it that you want to achieve, you know, whatever it may be? But by leading in the why and getting those that you are onboarding and those that you are hiring to believe in what you believe, they're going to perform as informal leaders. So you really want to really tie this to your mission, your vision, your values, and have a true understanding of what is the why that we are looking to gain. And from there, you can establish then how you're going to achieve that and what your end goal is. But really kind of thinking about this in this context, I think it's very easy for us to always think about, okay, what is it that we want to do? But that reverse method of how we're going to achieve that truly may prevent you from success and sustainability. So really think about this as you put your mind to what it is you want to achieve and tie it to that why.
Okay, so Quest is a framework that I like to use when we're assessing all these great ideas to turn around the immediate care centers or whatever else. The acronym QUEST stands for Quality, Utilization, Efficiency, Satisfaction, and Teamwork. You can see a link, and you'll get these in the notes that we send out afterwards, to a Medscape article that'll talk about this in more detail. But the gist is that anytime we have a new idea, we want to look at each of these components and, of course, make sure that they're improving from the current state. They don't all have to improve. Maybe only a couple will, but as long as the others don't get worse, your idea benefit has a margin, and that's the Quest future minus the Quest current. So to really figure out the value of the idea, though, you have to figure out the idea cost. And cost is any obstacle, so it could be money, it could be time, it could be distraction. And we have to think out of our own silo when we're trying to improve things for the system. So an example is we all come up with great EMR fixes, things that could be tweaked. And we all know that the IT department has almost zero bandwidth. And so when we try to wedge in our project, which is a great idea and achieves the idea benefit margin, the IT department might be able to tell us that there's 3 other projects that are much more important because maybe they affect patient safety and not just efficiency. So this is a good framework to share with staff when you're assessing new ideas. So now to get those ideas rolling, we've probably seen this model called the law of diffusion of innovation, which was started by Everett Rogers. He's a communication theorist, sociologist at Iowa State, and he talks about the source of traction for new ideas. And I suspect everybody on this call is probably in the innovator or early adopter grouping. And generally, when you're starting a new program or improving a currently existing program, it's not that we have to influence too many people that are in this category. So this is the 16% that are the easy ones. The focus is really the early majority. These are the people that want to believe. Everybody's comfortable in their current state, but it makes sense to them. They will follow the lead. And what we need to see is that as these people are recruited and as you get close to the midline, the rest is going to happen. So our focus does not have to be on the laggards, the ones that really will totally resist change. As innovators and early adopters, our focus is on the early majority, and then there'll be just a natural continuum once we have momentum. And so this is a kind of a cool change management way to think about things. This was developed by a behavioral psychologist named B.J. Fogg. He also founded the Stanford Behavior Design Lab. And what I like about this is when we really want change to happen, the best way for it to happen is that our staff come up with the idea. So, you know, really we start out with this goal. There's different techniques to achieve our goal. And what we want to do is we want to present the opportunities or the problem to our staff. And if they can see that each piece is both easy to do and something they're motivated to do, it will naturally happen. And it'll be a pleasure for them to move things forward. So if you see that motivation is low, the focus has to be on persuasion. What sort of incentives can we put in place? If we think that there's motivation, but to get there it's pretty hard, we have to look on ways to make it easy for staff. Either break it down into pieces or look for obstacles and try to eliminate them as leaders. This will get our staff focused on how to improve and coming up with great ideas.
And here's what we, share with you. It's really the model of managing change. And this is really a model that Edward Elmhurst used as they were really thinking about, okay, what do we need to do? We know that there's gaps in our care, and how do we really achieve the success that we want? So when you think about that, make sure that you're tying what you're doing to your vision. And each one of these components are really necessary to achieve success. So for example, without your vision, you're going to find that you're going to have members of your team and staff who are just truly confused as to, again, back to that why. What is our goal here? Also skills. If we don't have the proper people involved with the necessary skills, we're going to find that there's going to be some anxiety, uncertainty, and maybe not feeling as confident in their ability to perform what we need them to do to reach our successes. As well as incentives, and again, it doesn't have to be monetary, but there does need to be some type of an incentive that's tied to their why, to their individual why. Otherwise, you may see that you're going to have some resistance, and sometimes one resistor can be enough to prevent you from that true success that you're looking for. And then resources. Obviously, we need resources. We can't achieve what we want without having the proper resources to get there, and as well as your action plan. So we need to have a strong, clear action plan where everybody is very clear and part of and determining. And having each and every one of these is really what's going to allow you and your organization to get to that success. And so then what did this look like for Edward Elmhurst? Well, really, it's collaboration. And as everybody knows, you have to have the proper people and the right people that are at the table to really execute your strategy. So, you're working across, boundaries, and you're encouraging staff to participate and really breaking down any silos that may be happening within your organization. So to give you an example of what this did look like at Edward Elmhurst, the key stakeholders that were at this table and part of this conversation were, of course, leadership, because you have to have the right leaders there to create, open the pathway and allow these their buy-in, support, and open these pathways. But that leadership was nursing and physicians. And then, as we've mentioned over and over again today, you have to have your frontline staff involved. You really need them to get involved so, that they have a voice in this. They are your change agents. They are the ones that truly perhaps maybe know the gaps that are happening in the organization. And with their inputs, you're going to get buy-in, and you're going to have other members also buy in and that consistency you're looking to achieve. And then, of course, ancillary departments. That is crucial. So, for example, in our immediate care, we have other members who are involved with the care of patients who walk through our doors, from your registration staff, your lab, radiology, all examples of people who are going to participate in the care that patients are going to receive at your facility. So make sure they're part of this discussion and they're at the table. Within our organization, we really focused on utilizing a Lean Six Sigma principle. So we focused on, the model of defining, what it was that we needed to do, measuring, analyzing, improving, and then controlling, which really meant taking a current look at the process that we were at today, those metrics, the baseline, and what we were going to measure as we move forward.
So we came up with a whole bunch of operational improvements. I'm going to just kind of list them. For instance, we did things like revise the schedules to match the influx. We added techs instead of only nurses. We actually were able to do some of this as volume was growing, so it didn't really disrupt anybody that was currently there. We refined the charge nurse role, and that's the instrumental person on improving throughput. We added a system called Smart Contact so that we could get the voice of the patient and share that information at each department meeting. We moved out OC Health, which made a big difference. They were in the same building, but in a different area, managed by a different team. We reduced our PRN providers. They were people that were essentially less committed. We did a lot of things to improve patient flow. Most of these relate to shifting from serial processing to parallel processing. We used to have a queue. Everybody that was coming in for OC Health, outpatient testing, and immediate care were in the same line, so we changed that. They went right to one line, and essentially it wasn't really a queue because they went right back. Registration started doing that in the back with portable computers. If there was an open room, the patient went to it immediately. We also leveraged our EMR, which is Epic. Simple things like creating a tracker board so you could see the waiting room. We knew that there were open rooms. They were expected to go right back. The old system was charts, and there was no visual of who could be moved first, second, third.
We were also able to really identify amongst our 37 providers a physician empathy score, and this really allowed us to identify those top and low performers with a mean score of 58 for those who were above, with that 50% above the standard deviation. We were able to offer praise and really acknowledge those providers, and those who were below that standard deviation of the lowest 15%, we were able to coach them. And not only were we able to coach and really work with those particular providers, but this was also very helpful to the medical director as he was able to identify if there were any providers who perhaps were experiencing burnout and really be able to provide them with services and support that they needed to protect their profession as well as patients walking through our door. So that was very helpful in making sure that that engagement was happening with the providers as well. We also, our goal was to obviously improve. So we began this discussion, that tabletop discussion, in 2014. In 2015 is when our changes were implemented, and as you can see, we've continued to climb. It's one thing to move your percentile rank, but to move that top box score, as you all know, is not as easy. So this has been an ongoing process, but we've been able to continue to move the mark by capturing patient feedback through the surveys of Ganey, as well as our smart ER contacts when patients leave the facility. And then as well, identify any comments that we were hearing back from our patients to really close those gaps and make sure that we were incorporating the voice of the patient into all the changes that were happening.
Yep, go ahead, Julie.
Yeah, our other goal was really to improve that time of arrival to see your provider. So when we began this new process, it was about a 44-minute wait to see the provider. Not only have we achieved our goal of that 20-minute, but we've also are now at around 11-minute wait time from arrival to see the provider. So again, this has been a huge throughput process with lots of variables, but really streamlining this in collaboration with everybody involved to get patients into the room and begin services there versus that serial process that we had prior to this has helped achieve this.
So Julie talked a little bit about the physician empathy score, and this is where it comes from. Everybody that's sent home from the Immediate Care Center gets a quick 5-question survey. The first 2 are well-being, to make sure that there's no medical issues, they don't have any problems with follow-up. And then we get into 1 question each for the doc, the nursing staff, and just a catch-all. The doc question basically asks if what was the level of concern that he or she showed for your well-being? So did they apply their knowledge and experience? Were they paying attention? Were they distracted with calls or whatever? If the patient gave a very high ranking, that was the only thing that counted, the top box score. This is then in the middle of the monthly reports given to the medical director and the provider, and you can see that the top box scores generally improved across all the providers. By eliminating the PRN docs, you can see that the number of patients seen went up. So we had lots of high ends, lots of patients contacted. And so we see people fall into a certain level and stay there. And as Julie mentioned, if they started drifting down, it was more representative of a personal problem that we could address in sit-down meetings. And what's interesting as well is the staff, the providers got a report 2 days after their shift. They could see things like their productivity, their utilization. An important metric, I think, is turnaround time for discharged patients, how quickly they can move the room. And then they saw all the patient comments, whether it had to do with a medical issue or a service issue, so they can get a real good idea of how their shift went. And that concludes the webinar. We certainly welcome comments if anybody wants to use the chat